computer's not full yet.
I took off 30 gig. We're good. Should be good. Okay. Sandy, is it recording?
Yes.
Awesome.
Cool. All right. So this is, I guess we'll call it a case study of applying results of a systematic review to practice. And yes, bearing in mind that I don't practice. And so this is my view, I guess, of how this might happen. We'll see how it goes. All right, so this is a guy who comes into your practice. He has a sore back. And the thing about having a sore back is there's absolutely no shortage of options for you. And actually what you get depends on who you turn up to first. And there is literally no limit to the absurdity of what you might end up getting for your back pain. Yeah, I don't know. I think it's Dr. Oz, but I don't know. I think you put the bowl on your head and bang it with a little.
There was just a certification course in that.
No doubt.
We like to alternate weekends.
But he doesn't realise how lucky he is, and he's lucky because he's turned up to see you guys, and he's going to get himself some pretty sweet ass EBP. And so you get him into the clinic, and you do your baseline assessment and ask him what's going on. He said back pain, on and off, comes and goes. This episode's hanging around, giving him the shits, not happy with it. He's had a bit of physio before, had some manual therapy, had a few exercises. Things are not going well though. He's been having to take some sick leave later. He likes to run, but he hasn't been able to. He's having some trouble sleeping. He's worried about not being able to work. He's got to look after his family. It's getting stressful. Pain's pretty high. Disability also pretty high. You give him a score on the hospital anxiety and depression scale, and again some reasonable scores on anxiety, not much on depression. And you give him Tampa scale, and again that's reasonably high. So he's concerned about moving around. He's a bit anxious about things, about worried about what's going on at home. So you do your physical, and you do whatever it is that you do. You push him and prod him a bit, and that hurts. And you get him to move around a bit, and he's not that happy with it. And he has a pain face like that. And so you can see not that happy. So you have a think about this and go, okay, we better hit him with the start back. So you whip out your start back, put his name on the top, and you get him to fill it in. He does like that. And you need to score it. So you go and see Neil because you know he's good at maths. And he gets, Neil sends it off to George. Amazingly, between the two of them, they end up with the right score. So it ends up with a 6 out of 9 for the total score and a 4 out of 6 for the subscale. And so you look at your algorithm, and that comes out at high risk. So you're getting a picture there that things are not going that great with a guy. And I guess if we're thinking about chronic back pain, we think about the symptoms that have been around for a while. But as you can imagine, all people with back pain that's lasted for a certain time, they do come in slightly different flavours, these people, and you'll get more simple and to more complex presentations. And this is often about the sorts of other things that are going on along with their pain. And so you might conceptualise all your sort of treatment options, and you can kind of categorise them into simple and pretty easy things and medium sorts of things, and more complex things. And again, this sort of fits with some of the literature out there into looking at the different, I guess, subgroups of people in terms of what's going on. So you think, okay, this guy looks like he's up the complex end of things, and so maybe we'll have a think about multidisciplinary rehabilitation. Had a look in the guidelines, and that suggests that might be a thing. And so you have a look at these nice guidelines. Looks like it's a pretty impressive list of people who've put them together. Yeah. And you had a look, what does it say about multidisciplinary rehabilitation? And it says it can be considered if previous treatments are not effective. Okay? And it also says it can be considered if there are significant psychological barriers to recovery. And so you go back, and we go back and have a look at his baseline assessment. And so we start to look through these sorts of things. He's had some therapy before. He's worried about stuff. He's in this high risk sort of group, some sort of psychosocial yellow flags, if you like. And so it's starting to look like he may fit this sort of criteria that's outlined in that amazing set of guidelines. So you have a bit of a look and you decide, okay, I need to find some evidence. So what am I going to do? I'm thinking multidisciplinary care might be a good idea for this fella. So okay, let's start with Cochrane. Good place to start. And the nice thing is we can do it pretty simply with Cochrane. So we can just click on the back and neck group. So everything which is, if this is something about chronic back pain, best chance it's going to be in the back and neck group. Type in something pretty simple, multidisciplinary, that should fit. Hit search, and 5 come up. It's fantastic. That's not too much work. It's pretty easy. So then you can just start looking through these titles. You look at the first one, subacute, not interested. Look at this third one. This is about advice to stay active. It's not about multidisciplinary care. I'm not interested. Fourth one, something about cancer. Fifth one, something about after surgery. Look at that. Multidisciplinary biopsychosocial rehabilitation for chronic low back pain. Fantastic. Loving it. Yeah. So you think to yourself, all right, let's click through and have a bit of a closer look. Title looks good. List of authors, not bad. So the first thing we might want to check, we want to see that it's up to date, right? And you have a look, 2014, all right, we're in the ballpark. We're not a million miles away. Then we want to have a quick look over the abstract. What does the abstract do for you? It tells you whether the rest of the paper is worth reading. Okay, so we have a quick look over the abstract. The other thing that you might want to know from the abstract is whether there's actually anything there. And so if you've read a few systematic reviews, you'll know that sometimes they're pretty empty. There might be 1 or 2 studies. There might be a whole heap of small and crappy studies. If there's no studies in there, this is not going to inform your practice, right? So again, just a quick eyeball. What's it showing? Okay, there's 41 RCTs. There's 7,000 patients that have been through them all. Starting to think, all right, there is a body of evidence there to be looking at. And what's it showing? And it is, again, this idea of risk of bias. Okay, 13 out of 41 were low risk of bias. All right, so at least some of the information there looks like it might be of decent quality. So what's it showing? Okay, there's moderate to low quality evidence that it's more effective in reducing pain and disability. Okay, so we're starting to get a picture here that it's possibly worth reading on. Okay, so this might be, and it's again, more effective than physical treatments. So again, we're just gathering some information about whether it's worth digging into this and seeing whether it's something which might be able to inform your practice. Have a quick look down at the conclusions, and they say the effects are of modest magnitude and should be balanced against resource requirements. So again, it's just this first little screen is really about just making sure it's on topic. So does it fit what you're interested in? But also, is there something there which might be which means it's worth your time going through and reading this. So then you've got a number of questions. So you need to think about what do I need to ask myself about this to see what it's what should I be thinking about when I read this paper. And really this is very, very similar to using that CAST tool that you're familiar with here. And so this is, these relevant questions, not just for SRs, for systematic reviews. So are the results believable? Okay. Can I apply them to my patients? And then this third step was how am I going to incorporate these into my practice? So we'll start with number one, best place to start. So you want to have a look, are the results believable? There's two parts to this, right? So there's something about the quality of the systematic review. Have the people who've done the systematic review done a good job of it? And then secondly, what about the quality of the studies which are included? Okay, so both those things are important when we're thinking about how or if we're going to use the results from a systematic review. Can I apply these to my patients? So that's really about, do the patients who are in the included studies look something like the person standing in front of you? And then this is going to be about saying to the patient, what do you reckon about this? This is what I can offer you. This is about what I think will happen. Are you into it? Okay. So as you'll see, some of these things refer strictly to the review itself and others to the person standing in front of you. Then you're going to think about these other issues. So I've got these results, I've got this information. Is it possible for me to use these in my practice? And so there's questions around how much does this cost? What's available? All these sorts of things. Do I have the skills to do it, etc. So these are the questions. So we're just going to run through these pretty quickly. So first of all, are the results believable? I mean, if we're really honest, you didn't really have to go past the author list, right? So we'll be pretty happy with that. So we've got this quality in two parts, as I mentioned. This is really the systematic review quality and the included studies quality. So first of all, it's a Cochrane review. As Neil said, that's not perfect, but you're probably maybe half a step ahead, right, on average. And as Neil mentioned, you want to see a protocol. There was a protocol, okay? It's a Cochrane review, so there had to have been a protocol beforehand. Have a quick look through the searches. They look pretty comprehensive. Came up with several databases. And as Neil mentioned very quickly, a unique thing about Cochrane protocols is that they get peer reviewed. So if you think about what that means is you say, this is what I'm going to do. You send it in. Someone is assigned by Cochrane to have a look over it, and they're going to say, yes, do this, no, do that. What about this, etc., etc. And so, again, if you think about that, that's a really helpful thing. So that's really about, or you haven't defined how you're going to do this. So it's another set of eyes, another quality check over what you're planning to do. It's a really useful step in the process, which you don't get with other reviews. So if you just put something up on Prospero, it's not peer reviewed.
It's worth adding more and more Cochrane, also including lay people as peer reviewers of protocols as well as reviews, and trying to bring the patient voice into that process, which I think is it can be hard to navigate as a reviewer, but it's about having that voice.
So getting at this question, am I going to believe the results in this review? Said protocol's good, searches look okay. It did all those double screening of the quality assessment and the data extraction, etc. There's information about how they synthesize the data, and everything's available. So as Neil mentioned, there's in a Cochrane review, it's really comprehensive. So if you need to go and find something, it's there. All right, you may have to go digging through lots of pages, but so I mean, by point of interest, this review that we did was longer than my PhD thesis. It was 250 pages or something like that at the end of it. So then so the next step then is thinking about the quality of the evidence. So this speaks to the quality of those included studies. And Neil mentioned the sort of figure that Cochrane reviews come up with. So this is really an aggregate figure. So each of those elements of the Cochrane risk of bias tool are down the left. And then the green ones represent the proportion of those included studies which met that criterion. The yellow is where it's unclear, and the red is where it was not met. So roughly the proportion of green is low risk, yellow unclear, and red high risk. The other thing that's mentioned is how these were operationalised. Okay, so if you go into the review, you can check out. And so you might be interested to look at things like this blinding issue. Okay, it looks like none of the, you wouldn't expect participants to be blind. You wouldn't expect clinicians to be blind, given the nature of the things that we're talking about. But you might say, okay, did none of them assess outcome? Did none of them blind outcome assessors? You can go into the review and they'll say, well, the way that we defined blinding of outcome was this. And it would say something about self-reported outcomes, and you'll say, fair enough, that makes sense. You might look at something like selective reporting. Okay, it looks like everything's unclear there. You go into it and look and say, why can't they tell whether they're selectively reported? And the reason is that the authors took a view that unless there's a published protocol, or unless I can access that, I'm going to say it's not clear whether they've reported all the outcomes or not. So that's just an operational decision about how they've rated that sort of thing. The point is that the information is all there if you need to get it. So are the results believable? So the quality of the evidence, and so you have a quick look in the methods. And what they say here is that in order to incorporate those methodological quality assessments into the findings, essentially what this is saying is we divided the studies into, what do we do? Okay, to low risk of bias and everything else. We had a look at the meta-analysis, so the effect sizes of everything. Okay, so the full pooled effect. We look at that effect size. Then we just took out the studies which are high quality, and we had a look at that effect size as well. Okay, so what we want to see is whether they're the same or different. And if they're the same, we're not so worried about the quality of those studies. So they did that. That's in the methods. You have a look in the results, and it says, in general, pooled effect sizes from the high quality studies were of similar magnitude to those from all included studies. And this was the case regardless of how high quality was defined. They defined high quality a couple of ways and tried, so this is a sensitivity analysis, just to see whether there's some impact of the low quality studies on the size of the effect. So you're saying, we're thinking here, okay, what's the quality of the evidence like? They've had a look at that. It doesn't appear that having some low quality studies into their effect estimate is making a difference on that. So can I apply these results to my patients? So this first question is around, do the patients in the included studies look like a guy who's standing in front of me? Okay. And so first of all, we're going to have a look at the results. And it says patients were usually referred to rehabilitation by primary care practitioners or insurance providers. What about our guy in front of me? He's rocked up off the street, but he's been in contact with primary care before. Maybe that is or isn't the same, somewhat similar. Average age was between 40 and 45. So this is the mean of all the studies. Gender balance was varied. Duration of symptoms was more than a year. So it's not a million miles from what your guy standing in front of you is. We have a look at his pain and that the clinical characteristics compared to the ones in the study. And again, baseline pain, 4.5 to 6, disability, 11 to 14. So it looks like he's sort of on the high end of the sort of mean of those studies. But again, he's not a million miles away from what these studies are saying. So you're starting to think, okay, not perfect, but it's probably reasonably close. So then, in order to judge patient preferences, so this is really a discussion that's going to go on with the patient. And so this is what you're offering, okay? So we're saying if we do this compared to usual care or compared to a purely physical treatment, this is about the difference we can expect. This is about the difference on pain. This is about the difference on disability. This is about the difference on work outcomes. So that's part of that. That becomes part of that conversation with the patient. You have a look at the tables, and this is really around the sorts of interventions. So some of them are inpatient interventions. Likely you're going to have a chat with a guy and say, do you want to go and sit in hospital for 3 weeks? He's going to say, no, I'm not doing that. So, okay, there's outpatients. What do they look like? They're about 5 to 12 weeks. And so again, this is just about saying, this is what we're offering. This is about what we expect. Is this something that you look like you could get into? So incorporating these findings into practice. And so we've got to think about the costs and availability of these services. So multidisciplinary rehab programs tend to be pretty expensive. They tend to be in hospitals. And if you don't have the capacity to pay a lot yourself, if they're through a public system, you guys don't really do that here, do you? No. So where they are available, they tend to be very inaccessible anyway. Okay, so and the issue is that the throughput from these sorts of programs is generally pretty low. So oftentimes there's a really long waiting list. So you think, okay, what else? What are the other options here? So you have a look in the methods, and one of the key components of these programs that has been picked out is this idea of coordination. And so the multidisciplinary aspect, the idea that we've got these different professionals who are all together treating this patient, they need to be working together. So it's not about setting someone here for physio, here for psych. There's some coordination and communication, which begs the question, who's going to coordinate the care? And maybe another question is, who's going to coordinate the care if you don't? Okay? And so we move on. So what are the roles? So who are the people, who are the likely characters that might be involved? And so these are some, I guess, some of the obvious candidates. And again, if we think about the sorts of programs, we had a look at the sorts of programs which are in the included studies. They include a physical component, they include a psychological component, and they usually include some sort of contact with a physician as well. So we think, well, who are the people who are available? These are the types of people. So what are we all going to do? So we've already decided physio is going to coordinate the care. So that means we're going to take responsibility for communication, keep on top of progress, and ensure consistent messages. Physio is going to take responsibility for the education and reassurance component and the physical intervention. Doctor's going to look after the medication, have a look at that, and the psychologist is going to lead these parts of it, which is generally within their remit. So that's a model that you might think, okay, this is starting to look like something which is perhaps a bit more feasible than spending 3 weeks in hospital. Okay, so what are you going to do? First pull is coordination. So that's as likely that may happen by phone. Okay, and so that might be telephone teleconference with the other clinicians. And you're also going to track progress. You're going to be looking at goals. You guys are massive fans of measurement now. You're going to be right into that. You're going to be selecting the constructs, which is going to be part of the negotiation with the patient. And also then you're going to select appropriate measures for that. So you'll be thinking about the usual sorts of things. And these were the sorts of things that were in the included studies. You're going to do all these sorts of things, which you do anyway. I'm not really going to go through that, because you know more about that than I do. So you're going to do the physical intervention. You also know more than that than I do. But again, this is partly going to be thinking about what are some of the targets and what are some of the things which are feasible, what are some of the things which might be, some of the things which the patient is likely to engage with. So similarly, again, this is going to be a part of the negotiation. Psychologist and the GP, what are they going to do? And psychologist is going to reinforce the same messages. So again, this comes back to this idea that there has to be this coordination of care to ensure that everyone is on the same page. They're going to take responsibility for any CBT. and look at these sorts of things, perhaps some relaxation. GP, again, reinforcement of the same messages, and look at the medication review if there's any issues about weaning or how to deal with flare-ups, that sort of stuff. Cool, everyone's loving it. So good, it gets way better. Okay, about 3 months later, crackerjack. Asked him about his work. He's only had a couple of days sick leave in the last 4 weeks. He's back to running. It's pretty short, but he's getting there. Importantly, though, he feels like he has some strategies to deal with flare-ups. And you know that's going to happen because you're aware of the literature of the nature of this condition, and it's not hard to convince him that this is going to come and go and things will get a bit worse and a bit better. But he's now been given some tools to deal with that. So that's the story. So the question then is, what is going through this process of doing a search and having a look at this evidence? What's that added to you? What's that added for your well, it's added a justification, and it may be difficult. It may be problematic in some ways, depending on the patient, to say that, okay, I think you need to go and see a psychologist for something in particular, and or a GP. So it's provided some justification if that's what is helpful in that part of the consultation. Importantly as well, for amongst the other healthcare professionals, it's given a bit of a common language for communication. So it ensures that everyone has some idea of where we're heading with all of this. Maybe as well, it's a promotion of your services amongst some other healthcare professionals in the area as well. Okay, so maybe it gives the message that you're someone who's willing to work with other people, you're someone who's on top of the evidence, you're providing good care, you're committed to that sort of thing as well. It provides a guide for a model of care, so what to include without being prescriptive about this. There's a whole range of different types of interventions that are included. It gives you also, though, a basis of some really concrete evidence that you can talk to the patient about. Say, listen, if we do this, we have good reason to expect this is going to happen. And so I guess to aid that engagement with the patient. Some expectations regarding prognosis. Best off winning.
Has he had plastic surgery done as well? Because he looks a bit different.
Looks younger, doesn't he? It's because the pain's gone. So that's it.
What I like about what phrasing, what I like about that is it also, well, it says what to include, it also very nicely leaves out something that were still are pretty standard for a lot of PT practice here. A lot of passive modalities, like all of that electrotherapy from our previous study that we looked at. Most of those things are not in vaccine as well, but there's none of it.
But you know, the thing about this is it's a great idea, right? It's what we'd like to do. But the other thing about doing it is having a clear recognition of what the barriers are. Something we'll do tomorrow. Is that, okay, I want to be able to deliver this. And actually in the UK, where we've got this national free at the point of access healthcare system, when you work in primary care and you have a patient you think is complicated and should benefit from this, you're not getting into it unless you live at a certain postcode at the right time. It can be 2-year waiting list. There really is a lack of capacity on it. So that's another barrier, as well as making people communicate. But you only get there if you know what they are. Try and work proactively to do it. You can only do the best you can within restrictions. So, but you have to start from an idealized view, because otherwise you're going to fail whatever. You have to say, what's the best we could do? And then what can we do? To get closest to that.
And I think that hits on a really key part of the whole evidence-based practice ideal. Is this is not about either you do what's in the RCT or nothing, or you're not part of the club, it takes understanding of what's out there, and then that other step of integrating it with what's going on, and also integrating that with what's feasible.
This doesn't say anything that these practitioners all have to be under the same roof.
No.
Another nice step forward from implementation.
But again, that was my interpretation of something which might be feasible, because most of the programs, they are all under the same roof. But again, I assume that that's for the patient who turns up for you, unless you can or have that option available. What do you do then? Maybe there's something you can do to approximate what's going on here.
There's a lot of places. Chicago is an awful lot of resources that you don't get even 2 hours away.
Mm-hmm.
And those people end up having to come in here, which is, it's not fun to drive 20 minutes when you're back in. So 2 hours.
Mm-hmm.
So just as well, like, we're framing this in about multidisciplinary biopsychosocial rehabilitation. But actually, if you were to not demand that the rehabilitation was multidisciplinary, but that it was multimodal in terms of the physical and the psychological, you'd see very similar results. I mean, that's kind of something where they did the reviews were nice. It's that you could have well-trained rehabilitation professionals who are trained to deliver the psychological aspects of care, and potentially that might be a compromise.
Absolutely, yep. And I mean that was a decision that we had to make when we were doing this review, and probably the first really difficult decision that we faced was how to define what multidisciplinary care was. We took the view that if multidisciplinary care, multidisciplinary biopsychosocial care was going to work, the best chance would be if the most highly trained people within each of those, within the different components of the model, were delivering the intervention in the area of their specialty. And so we figured if we do the review this way and it shows nothing, then there's probably nothing in it.
Competency is king.
That's right. So that as I said, that would have been then the obvious question if we include everything in this review. But again, that's something we have to decide up front. And that's the decision that we took as an author group while we were preparing the protocol.
Should quality of care and sort of other components come into play in this? Based on what you're hearing, the psychologist is maybe giving them messages that aren't reinforcing the rest of their care, or maybe they're just not that good, or maybe they're exacerbating abuse-related sort of schemas.
Choose your partners, right?
Yeah.
Like how?
I guess that
what limits can you, in terms of influencing your patients?
I mean, I guess that's, as Neil said, I mean, ideally, you're connected with some other healthcare professionals in the area, and they're people that you trust and people that you can feel like you can pick up the phone and talk to, because this, as I guess I mentioned, it seemed to me one of the things that would be really important was that everyone is providing the same message. And so I guess that would be, I would see that as part of the job of coordinating care between everyone who's involved.
Are there any ways for someone to judge the competency of someone else? Like, I get, from the hospital perspective, I get questions a lot. So like, who should they refer their patients to for public blood physio? And one of the things after hearing about certain people that use more pressure, I'd ask, well, is the patient you're talking about, they've been abused? Is there some potential to where, I think Chicago is unique. I know that California has a huge number of public blood physios, so there's a choice there. But how could typical doctor be able to choose the right physio be able to suggest, or even like looking them up and trying to judge, like you move to a new town and you have 20 different psychologists to choose from. It's not easy to tell who's the best or who's.
You're right. I mean, I don't have an answer to that, and I think that's. I would think. Yeah, sure. I mean, I would think that is a relationship or a set of relationships that you would build up over time.
I think one way to know is the more engaged people are in the broader community and events that the more you get to know who people are. And it's all in relationships. And my view when I was working, I knew which orthopods I wanted to refer people to. But I knew that partly on rumour, partly on reputation, partly on what patients told me, partly on the ones I met. And there's no, I think there's a shortcut to it. And there's also error related to that. You soon learn. Patients tell you all sorts of interesting stories about it. And psychologists.
There's no really good easy answer to how to limit practice variability or understand what that is, and that goes back to the clinical practice guidelines. Are they good, and are we following them? Are two different questions.
And the other kind of really bold truth is that none of us always deliver absolute optimal care, because we fail in this really complex task of dealing with people who are, and it's really hard. And some days you have a day where you're all over it, and some days you don't. There's only so much that can be managed, controlled.
Yeah, messy. But I think things like this get it back to. I think things like this get it back to something you can at least use as some principles to sit on. But I think that it's easier now than like 10 years ago to be able to say we should probably be aiming between these limits, where it feels like 10 years ago that was like whatever, or that's how much I paid attention. I don't know.
Yeah, we had an event and had an expert from NICE come on. One of the things she said was, to this crowd of clinicians from all disciplines, whose responsibility do you think implementation and quality improvement of services is? And it's everyone. But I think there's often a tendency for people to be passive and work within the systems that are imposed upon them. But if you go to work and accept that your system's imperfect, then you can be that. It sounds kind of idealistic, but if you're not looking to be that agent of improvement, then everything stays the same, and then none of us have the right to know. But it takes people, in the end, for it to get better, it takes people, and people create great examples, and if they're great, other people listen, and they catch on. Slowly but surely, it's really actually much harder to do it through policy from some top down. It's the grassroots to change stuff.
Speaking about confirmation bias massively there, I think it's the patients who go back to their doctors and say, I'm better. That then whatever that means to them, that then the docs start to say, how is this happening? Because I thought this couldn't get better. And that can shift some care. It's slow.
How do you deal with in tertiary in clinic, sometimes they come in with 8 or 9 different medications all at once, and that's going to sort of inhibit how well they respond to working with you, but also the psychologist.
I don't know that
what is the role of
I don't know that I would say it's in the way. I think, and I don't know if you guys, like if you say you think about this differently, but like they're coming in as them, medicated as they are, and talking to them about what they want and where they're going and what all those meds are for is really important. But most people, when they come to us, they're like, I'd like to get off the pain meds, be it an opioid or some guys, Lyrica, those things. So we see if we can make a change as they are, because having them start a whole bunch of new stuff, especially stuff they're scared of, and take them off of medication without knowing how much it's helping them. You know, so you make a change where what they find is acceptable, and then that's usually when I have the conversation with them and the doctor about maybe they don't need this much stuff anymore. What are your thoughts? I've had lots of patients. I had a dude from last week. He's like, I'm gonna wean myself off the Lyrica. I'm like, okay, I'm gonna talk to your doctor about that. He's like, no, I got it under control. And what am I gonna do? He's gotta, you know, but he was on Lyrica and was still having pretty severe pain. He's having no pain now. I'd say, seeing how he does without pain medication is probably the right next step.
Did Jessica have any questions or comments?
Jessica is playing with C2 and 3, which are her children. Swimming and such in the backyard.
Awesome.
I need to be helped.
Sounds like a good plan.
Well, I think that's up.
I think so.
So tomorrow is all about back pain, really, and I think we're going to talk about. Steve's going to talk about epidemiology and public health kind of aspects to that. I'm going to talk about clinical guidelines, and there's this opportunity for people to suggest papers that we can all look at fresh. And then that'll be the end. My goodness.
I know it's so good here.
Sarah, I do pretty much the same, except for I probably rely more heavily on the physicians.
Getting more used to the small group teaching.
You wait for the doctor to say they're ready.
No,
Difference
no,
with
I
the
think sure
university,
the doc
I think,
knows if someone's wanting.
I let the doc know, but I'm not the patient's mom,
Oh, yeah.
so I can't be like,
No, I
you
like-
can't do that until you talk to your doctor. Like, he's a grown man.
True. All true.
So yeah, no, I do communicate with the doctor, but whether or not the doctor